Thank you, Ross, for that very kind introduction, and all of you for coming today to this presentation where I'll be talking about a topic that I myself have not done any research on, but I've been involved now in supporting patients that have been undergoing clinical trials in sickle cell with gene therapy. And at Stanford soon we'll be starting a clinical trial, so we'll also be involved at Stanford soon. So I have no financial disclosures. So the main things I want to talk about today with you all is to explain how genetically altered stem cells for sickle cell disease are engineered and the different gene therapy options that are available. Describe some of the clinical trials that are out there right now and completed and currently underway, and review how treatment of sickle cell disease with gene therapy impacts a patient's transfusion needs. We're a blood center, and our primary mission is to serve blood products to the hospital. So these patients do end up using a lot more blood products during the treatment period. So I'll talk about that a little bit with you as well. So history of sickle cell disease. In 1910, sickle cell hemoglobin was detected in circulation by James Herrick. And in 1956, it was a point mutation underlying sickle cell disease was determined. It is the most common heritable hematologic disease in humans. And worldwide, there's about 275,000 infants born each year with sickle cell disease. And in the US, about 90,000 people have sickle cell disease, about 1 in 500 births in African Americans. So what countries see the most sickle cell disease? It makes sense that in the African countries, it's about 1 to 2% of their population has sickle cell disease. So it's a large number of people. But even in the US, places in Europe, we also have a significant number of people per 100,000 births. And that's because we have a lot of African Americans living here. So what is sickle cell disease? What causes it? So in a normal hemoglobin, so we all have hemoglobin. In a normal hemoglobin, we have 2 beta chains and 2 alpha chains. And with sickle cell disease, the problem is in the beta chains. And it's amazing. It is one change in an amino acid at position 6 on your beta hemoglobin gene that causes sickle cell disease. So it's normally so people inherit 1 beta gene, beta globulin gene from their mom, 1 from dad. And in the 6th position, you see the amino acid glutamic acid. In sickle cell disease, both alleles, so both from mom and dad, you see the substitution with a valine. So that single change in the amino acid is what causes sickle cell disease. And people that have sickle cell trait, they don't have the full-blown disease because they have 1 normal beta globulin gene and 1 that has the valine substitution. But in people with sickle cell trait, they can live normal lives, and they typically don't have issues with anemia or the problems that you see in sickle cell disease. And really, it's that single change, if you get both of your alleles having that's what causes essentially these hemoglobin S polymers to form, which will then create these sickle blood cells. That's why it's called sickle cell. So a little bit more about what's going on here is that when people have both of the genes that have the mutation, you have your hemoglobin forming these long polymers of sickle hemoglobin. Then they align into fibers, align into parallel rods, and that's what causes that deformity of the red blood cell. And that formation of the polymer does depend on a few things, like that patient's oxygen status, how much hemoglobin S they have, and other factors like temperature. And this is a very busy slide, but sickle cell disease is very complicated in terms of all the things it can do to the patient. And so the main thing is, yes, it does cause the cell to sickle. But also there's hemolysis. So the red cells explode because of that deformity and release hemoglobin, free hemoglobin, which then causes a whole cascade of events of activation of neutrophils, of the endothelium, and it causes occlusion. So between the sickled cells and just all this activation, it causes occlusions that then result in a lot of the symptoms that patients with sickle cell anemia have. So what do people with sickle cell anemia, what are some of the main complications? Well, those vaso-occlusions in the blood vessels can cause stroke. That's definitely one of the more severe side effects. It can cause issues in your kidneys with papillary necrosis. It can cause infarction in your bones, skin ulcers, spleen infarction. The hemolysis causes anemia, so decrease in your red blood cell counts. Some of the most difficult syndromes that people have is pain, so acute chest pain or just acute pain. And you'll hear a little bit at the end of the presentation. I'm going to play a 5-minute KQED radio interview with a patient that has sickle cell disease. She'll talk a little bit about how bad this pain can be. And then also infarction in the eyes affecting vision. So a lot of severe complications from sickle cell anemia. So what is the treatment that we now have and the prognosis? So we do have newborn screening now. Babies get immunized to help against some of the infections. And there is improved treatment, one of which is hydroxyurea, which is often used, and it induces hemoglobin F. I'm going to be talking a lot about hemoglobin F because that is one of the mechanisms by which gene therapy is working. Hemoglobin F is a hemoglobin we all have when we're babies. But as we get older, it's replaced by hemoglobin A. And in sickle cell patients, hemoglobin S. But hemoglobin F, if you increase that production, it actually inhibits hemoglobin S. So by doing hydroxyurea pushes up hemoglobin F levels in adults and thus decreases hemoglobin S and helps to treat the symptoms. Of course, we all know sickle cell anemia patients need a lot of transfusions. Chronic transfusions, either simple, meaning 1 or 2 units at a time, or exchange transfusions, where you're basically taking that patient's entire red cell volume and replacing it with donor blood to treat some of the more severe complications like stroke is a good example, or an acute chest syndrome. And antibiotics to treat the infections they are more prone to get. With all of this treatment, prognosis is relatively good in the sense that children will go into adulthood. So 94% of children with sickle cell disease will survive into adulthood. This is not the case in developing countries, unfortunately, but in the US, the majority will go into adulthood, but then what? So unfortunately, though, sickle cell disease patients do not live as long as non-sickle cell disease patients. So the median age is 58 years old. And they do tend to have higher rates of sickle cell disease-related complications in their 20s and 30s with higher healthcare costs. Young adults receive less transfusions and are less likely to be on treatments like hydroxyurea and chelation. Chelation is what we need to do when patients are transfused a lot. They get iron buildup. And so in a lot of these sickle cell disease patients, they get iron buildup, which can then also cause organ damage. But what we find is that the kids, when they're being managed, they're really monitored and tracked and treated regularly. And then when they transition into young adulthood, they're just not coming as often, and their treatment is not as maintained as it was in childhood, and that's why they start to get more complications. So the good news is a cure is possible, and that's one of the things I'll be talking about today. How can we cure sickle cell disease? So one way is an allogeneic stem cell transplant. So from somebody who's a matched donor that doesn't have sickle cell disease, it's a bone marrow or stem cell transplant into the patient, and that will cure it. The other is gene therapy. So I'll talk a little bit about both of them. So this was an interesting just picture in Nature about steps to ease the burden, and they talked about these different options. So what is HCST is a stem cell transplant. And for matched related donors, so the indication is not everyone with sickle cell disease will get a bone marrow transplant. It's only those that have severe disease are considered a candidate for transplant, because transplant also has a lot of risks. So it's children with severe disease, they're having strokes, they're having recurrent chest syndrome, a lot of occlusive episodes despite getting treated with hydroxyurea and transfusion. Most of the time, bone marrow-derived stem cells are used, but now actually people are starting to use more of the peripheral blood stem cells and cord blood cells as well. The patient gets myeloablative conditioning, which basically means you have to wipe out their whole immune system and then transplant in the donors, so then the donors will engraft and become the patient's new immune system. And how does it work? It works great, especially in kids. So when you're younger than 16 years old, the 5-year survival is 95%. 93% have no more sickle cell disease events. And the 5-year survival free of one of the complications is graft versus host disease, 86%. For older children and young adults, the odds are not as good, but still pretty good. So it's a very good option. But the big if is if you have a matched donor. So this really depends on patients having a fully matched donor. And that's the problem. So only 10 to 20% of sickle cell disease patients will actually have an HLA matched sibling donor or a donor in just the National Marrow Donor Program. And also, as people get older, the more risk there are, so people don't really do as many of these stem cell transplants in older people. And the risks are graft versus host disease, infections because your immune system is decreased during the transplant period, and infertility from all the treatments. So there is also other possibilities. If you don't have a sibling, you can use an unrelated donor, partially matched donor, cord blood transplants. But all of these things are still considered, need to be done within a clinical trial or a research study because there is risk. The only ones that does not need to go through a research protocol in a clinical trial is if you have a matched sibling donor, because that has shown such good success that you can do that if that option is available outside of a clinical trial. This graph really shows how challenging it is for certain ethnic groups to find a matched donor in the community. So this line here is for white Europeans, and essentially their chance, in 2017, their chance of finding a matched bone marrow donor is over 80%. Now, one of the lowest is African Americans here in the, let's see, the red boxes, and they're only about less than 20% in 2017. So it's a significant difference, and that's why it is so hard to find sickle cell disease patients a bone marrow match. This is some data from a hospital that I used to work with in the Bay Area, and they were doing these transplants. So just looking at their numbers of 23 transplants in sickle cell patients, the majority were sibling matched donors, but there were a few matched unrelated donors, one cord blood, one mismatched related donor. Most of them were children. There were 3 patients that were adults. The key is 23 of 23 are still alive, and the majority of them were cured. 22 of 23 were disease-free survival, cured of their sickle cell disease. So what is gene therapy? And it is important to understand that background, because gene therapy uses transplant, but in a different way. So what it does is it uses the patient's own cells, which are then modified and then transplanted back into the patient. And so the success of stem cell transplant supports the concept of giving genetically engineered stem cells for patients that do not have a matched donor. So the pro is that the patient always has a donor. The donor is themselves, so you don't have to find any donors. There's no risk of graft versus host disease or rejection, which are things that can happen when you use somebody else's stem cells. And the main goals of gene therapy is to prevent that polymerization I showed of the hemoglobin S within the red cell, within each single red cell, and then also to have enough of your red cells modified so that you prevent that occlusion in the vessels. So the basic theory of how gene therapy works, and there's 2 types of gene therapy I'm going to talk about. One is gene replacement, and a lot of the early work was with this. Now there's a lot more focus on gene editing. Who's heard of Crispr? Everyone's heard of Crispr, right? So except people not in medicine, I think I mentioned it once, and someone said, oh, isn't that what I put my lettuce in the fridge? It's like, oh. Yes and no. So with gene replacement, you actually will replace the gene that is not functioning properly with a gene that's functioning correctly. And you use a lentivirus to transfer the gene into the patient's cells. In gene editing, you actually edit the patient's own gene to either fix it or stop it from being expressed. So here is the basic schematic. You have your patient, you collect stem cells from them either by a bone marrow harvest or by peripheral blood stem cells. You then take their stem cells and you modify it by either editing the gene or adding the correct gene. You have to do an ex vivo expansion of the stem cells, and then you take that product and you infuse it back into the patient after they've been conditioned and myeloablated. So basically transplanting their own cells back. So the same vector has been developed, can be used for both sickle cell disease and beta thal. I'm not going to talk a lot about beta thal, but the main things that you need to make it work is that if you use a vector, so the vector, I'm now going to be focusing on this gene replacement using a vector. That vector has to be able to transmit that gene, modified gene, in a very efficient way. And you have to make sure that it's not going to integrate somewhere in the genome where you don't want it to integrate. If it goes into the wrong spot, it can actually cause oncogenesis. And what's really interesting, they've developed a way to insert it into the gene so that it's only being expressed by red cells. So that's the other goal. So the main viruses that are used as vectors is a gamma virus, a lentivirus, and a foamy viruses. Lentiviruses are really the ones that are now used the most. It is a little scary, it's HIV-1 based, but I'll talk about how there's really been no effect in any of these studies of the HIV becoming reinduced to cause any sort of infection. So as I mentioned, the Achilles heel of this technology, and what's very scary, is that you can have this insertional oncogenesis, which then if you insert that gene into the wrong place, it can activate a neighboring oncogene, which then causes expansion and things like MDS, myelodysplastic syndrome, or leukemia. And this is very scary. So, and it has happened, not in any of the sickle cell anemia patients, but in patients with severe combined immunodeficiency, Wiskott-Aldrich syndrome. These patients have also been treated with gene therapy. They used the gamma retrovirus, and there were 5 of these patients that actually developed leukemia because the vector inserted next to an oncogene. So it's definitely a scary thing to think about. The theoretical risk also of the propagation of this HIV-1 virus is theoretical, highly unlikely, never been shown in any clinical trials, but the oncogenesis is real, and when you're developing a vector and your mechanism, you have to make sure that it's not going to integrate next to an oncogene. So in terms of sickle cell disease, what gene do you want to transfer? And there's a few different options, and they have developed a way to insert it into the genome in a way that it's only expressed in the red cell, so erythroid-specific expression, which is what you want. So one option is you can just give the patient a normal beta globin gene. Another option is you can give the hemoglobin F gene, because we talked about how that suppresses hemoglobin S. But what's really cool is people are saying, why don't we combine the two? So they create like a super globin gene, where they take the beta globin gene and they figured out what about hemoglobin F suppresses hemoglobin S. And it made that into this kind of like a super beta globin gene. And this is what it's been called. AT87Q is one of these super beta-like genes. And what they did is they mutated codon 87 to introduce the amino acid that is responsible for the anti-sickling activity of hemoglobin F. That's the gamma globulin. And what's nice about this is that when you do clinical trials and the patient, if they graft and start making this special hemoglobin, in the testing where you test for hemoglobin, it actually comes out as a separate peak, so you can very clearly see how much of this modified hemoglobin is being expressed by the patient. And then at what percentage do you need to get the patient for them to stop having their symptoms and their disease. And this is just a schematic, we won't go into this, but of what one of these BB305 globin genes look like. And so far, in all the pre-studies, it was not ever inserting into next to an oncogene, so that problem wasn't occurring. So in patients with sickle cell disease and hereditary persistence of fetal hemoglobin, so there are some patients with this, we know that if you have about 20% of your hemoglobin F, this will inhibit the hemoglobin S polymerization and alleviate complications of sickle cell disease. So you don't need to get to like 100% of hemoglobin F or the special globin gene being expressed. You really only have to get to 30%, which is good, so that it does help in saying how much do we actually need to make this treatment? Because we know that even if you do everything right and you incubate the cells with the vector for the amount of time you're supposed to with the right factors, not all your stem cells end up getting transduced with this vector and the gene gets inserted. So in terms of where are we with milestones in gene therapy, a lot of the preclinical work happened in the 90s, I'd say. And then in the 2000s is when we started launching into clinical trials for sickle cell disease and beta thal. So next I want to talk about some of these trials, and also before that, just what is happening here. So first, you have your patient, and you want to collect their own CD34, and that's stem cells. So whenever I'm saying CD34 cells, I mean stem cells from the bone marrow. And usually they're procured either, like I said, bone marrow harvest, or you mobilize the patient, and you collect it via a stem cell collection with apheresis. Often you need to do multiple harvests or multiple collections in order to get enough drug product. After they get the CD34 from the patient, they get sent to the lab and they're enriched via purification. The CD34 cells are grown with stem cell factor and TPO for a few days, and then it's incubated with the lentivirus to allow it to take on the gene. And then it's frozen to get ready for the patient, but a small portion is taken out for release testing. Once release testing is completed and everything looks okay, the patient is given the green light to start myeloablation. So they start to get their marrow wiped out, and a few days after that, the drug is infused. The stem cells are infused. So the next thing I'm going to do is, I'm sure many of you have heard about patients in the news that are getting gene therapy. So I'm going to start walking you through some of the headlines that we've heard over the last few years about patients, and then walking you through what the trial was that they got. So the first ever patient that was treated with gene therapy to cure sickle cell disease was actually in France. And here's the headline from March 6, 2017. A French teen who was given gene therapy for sickle cell disease more than 2 years ago now has enough properly working blood cells to dodge the effects of the disorder, and really is transfusion independent now. So it was that HGB 205 study, and it enrolled the first sickle cell disease patient. And the primary endpoint was to assess the safety, tolerability, and success of that engraftment with CD34 cells from the patient that had been transduced with this special superglobin gene. So success and kinetics was one thing they wanted to look at. How long did it take for it to engraft? What was the 100-day mortality? What's the overall survival? And of course, was there any of those bad side effects, insertional oncogenesis, or the lentivirus starting to replicate on its own? And then secondary things is HPLC is how you measure how much of that globin gene. You look at the peak for that special globin gene. Another thing you'll hear me say a few times is vector copy number. So what they found is the number of vectors in each cell really correlates with how well that patient's going to do. So you need to have a good VCN for the treatment to work. And then, of course, one of the endpoints is them not having any symptoms or less symptoms and not needing transfusions anymore. So you really want to try to get these patients to be transfusion independent and not having symptoms. So the hemoglobin 205 study and many of the other trials, they're in pediatric patients and adult patients. They need to be eligible for a stem cell transplant but not have an available donor. And they have to have severe sickle cell disease, which is defined in multiple ways, but essentially being refractory to regular treatment, having repeated occlusive episodes, repeated chest syndrome, stroke, having developed red cell antibodies from lots of transfusion, heart issues, bone issues. So really the patient has to be doing not so well for finally them to be considered for gene therapy. And this is very similar to the graph I showed before, where you harvest from the patient, you transduce it with the lentivirus, you freeze the treated cells. Once that's done, you start treating the patient with the myeloablation, and then you infuse it into the patient. And you want to get a good dose of CD34 cells for it to work. And these studies, because it's so new, it's really important to follow these patients out for a long time. So this one, the protocol will follow the patient out for 15 years. So the results were that it worked. So it worked really well. And essentially this boy was enrolled into this trial because he was having pretty severe sickle cell disease. with multiple vaso-occlusive episodes, acute chest syndrome, about 1.6 events a year, and he needed chronic transfusion since 2010. He was enrolled, he's 13 years old, enrolled in 2014. He required 2 harvests to get enough cells for the treatment. They were transduced with the vector, huge whopping dose of CD34 cells. I think this is really what ensured the success. And then no major side effects, just the side effects you would expect from conditioning, but nothing related to the transduced cells, no oncogenesis and no replication of that lentivirus. And this is just showing he engrafted his neutrophils, he engrafted red cells, he stopped needing transfusions on day 88, he was discharged on day 50. And this graph is showing how this is the separate peak, the hemoglobin TQ S7Q. You can see increasing as the time goes on. And at 48% was enough for him to be symptom free. He didn't need to get to 100%. And the key was this vector copy number. So the VCN started out pretty well at about 1 in the drug product, and after it was infused, it just continued to increase. And here you can see it even peak at 3. So that's an important number. You really need to be between 1 and 3 or 1 and 4. So that was the first patient. Very cool. First thing that was published about sickle cell disease. But there's a lot of other clinical trials. So then in March of 2019, this patient, Janelle Steffensen, there was a CBS 60 Minutes reported on her, and she was part of another trial at the NIH. This trial is the HBG 206 study, and it's using that same vector but with some differences. So it's also enrolling people with severe sickle cell disease, looking at very similar secondary endpoints, but also just is there not necessarily is there a cure, but just is there a decrease in the number of occlusive episodes that the patient is having. Multiple different sites, and this is when I was involved in a patient who was enrolled in this study. So for this, again, now we're using autologous CD34 stem cells transduced with this lentivirus vector. The trial began in 2014, but the protocol was modified in 2016, and I'll explain why. But essentially in 2016, some of the changes were they increased the drug product VCN because they found that you do better if there's more of that. The other interesting thing was that they found that patients who had gotten more pre-harvest transfusions were doing better. They couldn't explain why, but the France patient had been transfusion dependent before the transplant, and other patients were also seeming to do better if they were getting transfused before. They also increased the target levels for the myeloablation. And group C was also changed because they no longer used a bone marrow harvest. For the first time, they were using a stem cell collection in that sickle cell disease patient. And we know that you get more CD34 when you do a stem cell apheresis versus bone marrow. And the problem was that the reason why this was not done earlier was because the main way, has anyone here ever donated their stem cells for a patient? I see someone nodding. So was it well, if you got a stem cell apheresis, you take a medicine called Neupogen or GCSF, and it boosts. Okay, all right, so yeah, so one of the ways, or the main way it's done is you take this medicine, Neupogen or GCSF, it boosts up your circulating stem cells, and then you sit for like a 4 to 8 hour apheresis collection that then collects those stem cells. The problem is you can't give GCSF to people with sickle cell disease because it induces those occlusive crises and episodes. So they found a new drug called Mozobil, which can be used in sickle cell disease patients and doesn't cause those events of stroke and occlusion. So Mozobil is primarily used in sickle cell disease patients. And so in this group C, there's 11 patients that have been enrolled so far. So the initial results of this study was not good. So when this was presented in, I think, the 2017 ASH meeting, everyone wanted to hear how the patients were doing, and it wasn't great. So really what they found in those first 7 patients in group A was that the drug product, first of all, wasn't getting high enough, the drug product VCN. And as soon as it was transplanted, it suddenly just dropped to really low levels. So you remember in that France patient, you saw the VCN go up to like maybe 3, between 3 and 2. Here, we couldn't even get a patient over 1. And so that was, the patients were not getting transfusion independent. were not having a significant cure. Except one patient, and this one patient, the main difference between the others was that this one patient was receiving chronic transfusions beforehand. So that's why they changed the protocol to say anyone has to be getting chronic transfusions, which is good they discovered that. For the blood center, that means more transfusion support to these patients who have very challenging transfusion needs. So in group A, the only thing they said did seem to work, they said it's some level of success, is that those 7 patients in group A, they weren't cured, but they had slightly less vaso-occlusive episodes. So here, the dark blue is 2 years pre-treatment, and the green is at last visit. So you can see the green is always lower than the blue. So they're saying, even though they weren't cured, they seem to be doing a little better. Group C, though, so the group that they changed the protocol and were doing the stem cell collections, totally different story. In this group, it's still pretty early, the data, things are working a lot better. So far, as of May 2018, and there'll be new data presented at the 2019 ASH meeting, but right now aren't available. So there were 6 patients that were treated. They needed to get this new requirement of 2 months of transfusions before the stem cell collection. The cell dose was really high, so this is great, 7.1 times 10 to the 6, more similar to that France patient. 4 VCN copies per cell, again, very good, and a large number of cells were transduced. This is all indicators that you will have a successful engraftment and successful treatment. And so far in these patients that have gotten it, they have all engrafted within an appropriate amount of time. And how are they doing? Right now, there's only one patient at the time this was released, 6 months out, and that one person was off transfusions. And the others are trending in the right direction with hemoglobin A increasing. So it's good news. So I think the modified protocol did work, and we will see more success in that clinical trial. I will skip this slide because that's pretty much what I said. And so now the next, there's just so many clinical trials, but I'm trying to highlight the ones that we hear about in the news. So this is a patient, Manny Johnson, 21, celebrated his birthday at Dana-Farber Cancer Institute after receiving gene therapy for his sickle cell anemia. He once had to get monthly blood transfusions for the disease. He hasn't had one in nearly 9 months since the treatment. So another success story here. And this patient got a different type of gene therapy. So in the last 2 trials I talked about, they were replacing the globin gene with that superglobin gene. This treatment is doing something different. It's still using a lentivirus, but instead of replacing the gene, they say, let's just target a gene, BC11A, that is the reason why adults don't make hemoglobin F, because we express a BC11A gene. But if you disrupt that expression, your body will suddenly start making more hemoglobin F. And so that's what this gene therapy is trying to do. It does specific inactivation of BC11A and increases the patient's production of hemoglobin F and then subsequently decreases hemoglobin S. So it's a different way to basically get to the same endpoint, which is less hemoglobin S. And in vitro studies have shown very good transduction, greater than 95% transduced, and achieving a high level of hemoglobin F. So in this clinical trial, the first patient cohort was greater than 18 years old. There were 3 patients enrolled, including the one, I think, in the picture. At least 3 months of protocols required transfusion. So again, requiring all of this transfusion before the stem cell transplant. Got the Mozobil or Plexifor mobilization and leukapheresis. Very nice doses of CD34, 3.3 to 6.7. Very nice VCN at 3.3 and 5.1. And so one patient, his labs are here, and you can see the hemoglobin F goes up to 60% at day 76. Was regularly transfused for 17 years, received the modified cells, had engraftment in 22 days, rapid induction of hemoglobin F, decreased hemolysis, and subsequently cure. So another way to treat this, or what to target, is targeting that BC11A, and that's important because that's what a lot of the Crispr is doing, and I'll talk about that. So it's important to understand that BC11A gene. What about transfusion support? So yes, it is great that if these patients are cured and they will no longer need transfusions, you have made them transfusion independent. But what we found is that in this peri-transplant, so pre and post-transplant, you actually have to give the patient a lot of red cells. And I'll talk about some of those challenges. So first, in the pre-transplant period, many of the protocols require a lot of transfusions to maintain a lower hemoglobin S and keeping the hemoglobin level at greater than 10. So 2 to 3 months of transfusion support before apheresis. Plus, usually before the apheresis and the bone marrow harvest, an exchange transfusion is ordered. And exchange transfusions can use 5 to 6 units of blood per exchange. So all this adds up. So pretty much, if you add up multiple exchange transfusions and other chronic transfusions, you end up needing about 15 to 18 red blood cells in that 2-month period before the transplant. Then after transplant, their counts are down. You have to wait for the engraftment to happen, which can take up to 30 days. So in that 1 month afterwards, you're also needing to give them a lot of transfusion support with both red blood cells and platelets to get them through that transplant period until their own blood cells engraft again. So basically, they check the CBC every day, and they transfuse to maintain a hemoglobin of between 9 and 11. And again, so about 10 to 15 units total are needed in this post-transplant period. So overall, you really need about 25 to 30 units in a 3 to 4 month period. And why this is significant in sickle cell disease patients is in the majority of patients, when you need a transfusion, what we match is the ABO and RH. So, if you're A positive, you can get A positive blood or O positive blood. If you're O positive, you can get O positive blood. So it's just a very basic ABO-RH match. In sickle cell patients, we actually try to match. They've shown they do better if you do what's called extended matching. So there's people who are in the field, there's a lot of other red cell antigens that we learn about, things like big C, big E, all kinds of letters, JKA, Duffy B, just lots of different antigens that for the sickle cell patient, we actually try to match those two, which ends up meaning that these patients can get rare blood, so blood that maybe 1 in only 1,000 donors will have, or is more prevalent in the African American population, so you have to collect more African Americans. So there has to be a lot of coordination between the blood center and the transplant center to make sure that the blood center can get enough, these 30 units of rare blood, to support the patient in this period of peri-transplantation. But the good news in the long run is that if it's all successful, the patient will not need red cells anymore. And that is the end goal. That's good for everybody. So let me talk about that one case that I've had to manage so far for a sickle cell disease patient who was in that HGB 206 trial. He was one of the patients enrolled in that group C that I talked about earlier. So we were notified of his potential transfusion needs early. So what was great is the hospital recognized that this patient was going to need a lot of blood and let us know well in advance that we needed to start preparing. And so we knew that there was going to be 3 exchanges with 6 units each, so 18 units over 2 months, plus we needed 10 to 15 units post-transplant, which meant 30 units over a 3-month period. And this patient really needed this is actually typical for sickle cell patients. It's not only ABO match, but match for big C, big E, Kel, Duffy A, JKB-S. And it's found in maybe like 20% of African Americans. So you really have to have a robust African American donor pool in order to support patients with sickle cell disease, because for Caucasians, it'll be less than 1%. 0.1% maybe that would have this phenotype. And in addition, this patient had actually formed antibodies to some of these, which meant that if we didn't give him the right blood, he could have a reaction. He, like many sickle cell disease patients, also had variants, which made things more complicated. And all the transfusions, like I said, had to be negative for lacking these antigens. So it did make it harder to find blood. So it was a real coordinated effort by the blood center, the medical directors, the collection team, the recruitment team, and the hospital. So the local team created that communicated regularly with the children's hospitals to see where in the care the patient was. We had increased recruitment efforts. I helped to write a letter, which was then used to send out to all of our African American donors to help encourage donation of blood to help support this patient in this very exciting new clinical trial. And the good news is the patient engrafted, and he is cured. So it's great news. It was a lot of effort and so much coordination, but in the end, well worth it. We were able to find enough blood to support him during that 3-month period, and he is one of the success stories. Okay, so that was all about the lentiviruses and using lentiviruses to either modify the gene or to replace a gene. But I'll tell you that I think is going to and is already being superseded by this other method, gene editing, where you actually go in there and edit the patient's own genes. So gene editing, the timeline, also similar to lentiviruses, but maybe more of the work happening in the last decade. In 2018 was the first clinical trial of sickle-cell disease and beta thal using gene editing with zinc fingers and Cas9, which I'll review in a little bit. So with gene editing, there's basically 4 types of platforms, and a lot of this, it's very complicated, and I will not get into the details, but there's 3 that are based off of just protein binding. So you have the homing endogenous meganuclease, the zinc finger, which you'll hear more about, transcription activator. These are all protein-based. And then you have your Cas9 guide RNA. This is CRISPR. So this is the actual name is Cas9 gRNA. And instead of it being just protein-based, it's also based on having a guide RNA that finds your target. So that's what makes it different. So I am just mostly going to focus on CRISPR. So CRISPR-Cas9, what does CRISPR stand for? It means clustered, regularly interspaced, short palindromic repeats associated with the Cas9. And there's actually a very interesting story about how this was even accidentally discovered in the Mediterranean, looking at organisms in the salt. It's just a very interesting story. It was totally one of these by accident. They discovered this thing that now is like revolutionizing medicine. So when we hear CRISPR, it's really referring to this Cas9 gRNA or guide RNA. The guide RNA is tailored to optimize binding with your DNA target site, so it allows the protein to bind exactly where you need it to bind, so the gene is targeting the gene you want. And then the Cas9, which is the protein part, is what cleaves the gene or inserts whatever you want it to insert. So here is just a schematic of it. So Cas9 is an enzyme, the protein, an enzyme that cuts the DNA, and you link it together with the guide RNA, which has the sequence that you're trying to target. It then seeks out your DNA and the specific sequence. The Cas9 unzips the DNA so that your guide RNA can bind to the right place. And when the match is complete, the Cas9 basically uses scissors to cut the target DNA, and then scientists can then edit based on what they're trying to change. So that's how it works. So for sickle cell disease, again, it's a similar approach with the lentivirus, but using a different method. So there's been this focus again on this BCL11A. If we can just stop BCL11A from being expressed, it will increase the patient's own expression of hemoglobin F, and that's good. So first is you just target that gene, the BCL11A, and you just cut it. You just randomly cut it, or you insert some other random thing that makes it stop working. So either of those, and more I think it's being used as you just cut it and that's it, and it stops the expression. So that's gene editing there. Or what you can do is you can actually more specifically cut it and repair it with the correct sequence. So here, this is not yet in a clinical trial, but is one of the things still in development. So that's another way that this could work. So far there have been multiple different clinical trials in a lot of different diseases to treat using gene editing. So sickle cell disease, so far there's only 1 clinical trial. I want to point out a few others. So one is HIV infection. So there has been a lot of work that if you disrupt this gene target of CCR5, you become more resistant to HIV. So there's a few clinical trials looking at that as well. So we did have in 2018, the first time the FDA accepted an application for a gene editing called BIV003 for sickle cell disease. It was the first gene editing therapy for sickle cell disease approved in the US. And what it did, so we have 8 adult patients. They received the usual ablation. They had apheresis to collect their CD34 cells, and this is using a zinc finger, so not the Crispr methodology. And it was a very small study, but it is the first one using the zinc finger, and it's happening in Oakland, Sacramento, and Detroit. But the one I want to talk about is the one using Crispr. So with Crispr, we talked about what that is, and data from preclinical studies showed that you can use a short guided RNA to create a double strand break in that BC11A. So that's what they're showing here. So again, you decrease or you stop BC11A from working and you increase your hemoglobin F. It's in preclinical trials, it's worked well. 90%, or preclinical studies, 90% of the stem cells were edited, caused hemoglobin F up to 40%, no off-target editing, and it was finally submitted to the FDA for a clinical trial in 2018. And what was interesting too is the FDA is definitely very interested in this kind of treatment, not just for sickle cell disease, but HIV, leukemia, and they're putting these treatments on what's called fast track designation. And what that means is that the FDA will have more meetings with the drug company to help expedite the approval of these drugs into a commercial scene so it's available to more patients. And so this is the CTX001 study using the CRISPR method that disrupts that BC11A. And there's 12 subjects that are being enrolled, 18 to 35 years old. They're going to expand to 45 subjects. You need to, again, have severe sickle cell disease with severe vaso-occlusive crises before enrollment. They're using the CD34 autologous cells modified with CRISPR-Cas9 to stop BCL11 gene. And it's happening in New York, Memphis, Nashville, and San Antonio. So this is what I wanted to share a patient story with you. So this is what came on recently in October, KQED. They actually first interviewed this patient in July and then interviewed her again in October. And it's a 5-minute video that I would like, or not video, but a radio interview I'd like you all to hear. And she's just a lovely patient and is doing really well.
Waiting to learn if the treatment is working. NPR Health correspondent Rob Stein introduced us to Victoria Gray this summer, and now he continues his exclusive look at her story.
Hi, good to see you.
Good to see you too.
I catch up with Victoria Gray in an apartment in Nashville, near the hospital where she volunteered for the first attempt to use the revolutionary gene editing technique called CRISPR to treat a genetic disease in the United States. Thank you so much for seeing us and letting us come over. I really appreciate it.
No problem.
Victoria's packing. She's finally going home tomorrow to see her 4 kids in Mississippi for the first time in months.
I'm excited. I'm very excited about it. It's going to be emotional for me. I miss hugs and kissing, just everything.
Those people so excited.
Yes, I am. Yes, I am.
She unzips a suitcase and starts pulling clothes from the closet.
My goodness, did I really bring all this?
Victoria has sickle cell disease, a terrible genetic disorder that turns her red blood cells into deformed sickle-shaped cells that clog her bloodstream, ravage her body, and torture her with agonizing bouts of pain.
The pain is excruciating. It's like being in a car accident and having lightning in your chest, and the pain that makes a grown woman like me scream.
Oh my God, it just sounds terrible.
Yeah, it's an overwhelming pain.
Like many sickle cell patients, Victoria had to drop out of school, quit work, spend weeks in the hospital away from her kids, worry whether she'll live to see them grow up.
It's horrible.
You have to live with that every day.
Yes. Knowing that I could have a stroke or a heart attack any time because I have these cells in me that are misshapen. Who wouldn't worry?
But now, Victoria has hope because doctors infused billions of her own cells back into her body this summer. Cells Victoria calls her
Super cells.
because scientists altered a gene in the cells with Crispr, which makes rewriting DNA really easy, to hopefully give Victoria normal, healthy red blood cells.
Super cells, yes. Yes, they gotta be super, do great things in my body. You know, and to help me be better, you know, and help me have more time with my kids and my family. That's one.
First your case done?
Yes.
But before Victoria can finish packing and go home, she has to stop by the TriStar Centennial Medical Center in Nashville again.
So how have you been doing?
I'm feeling good.
So yeah, this is a big moment, friend.
Yes.
Dr. Hyder Francoul at the Sarah Cannon Research Institute treated Victoria.
Are you excited about seeing the kids?
Yes, I am.
A big welcome sign for you in Mississippi?
No, because it's a surprise. No one knows them.
You did not tell them? Oh wow, so they don't know you are coming?
I'm just gonna show up tomorrow. I'm like, Mama's home.
That's pretty good. Okay, let's check you out.
Breath for me. Dr. Francoul says Victoria will come back once a month for checkups and blood tests to see if her supercells are producing something called fetal hemoglobin.
We are very hopeful that this will work for Victoria, but we don't know that yet.
So Victoria will also keep detailed diaries about her health, how much pain she's having, how much pain medication she needs, blood transfusions.
Victoria is a pioneer in this. We are very excited. This is a big moment for Victoria and for this pivotal trial, because if we can show that this therapy is safe and effective, it can potentially change the lives of many patients.
Dr. Francoul will also watch over Victoria for years to see if the treatment is preventing organ damage, heart attacks, strokes, and other complications that take the lives of sickle cell patients, and for any signs of any side effects from the treatment.
My hope and dream for Victoria is to allow her to spend quality time with her family, go to the park with them, play with them, without having to struggle with pain and weakness. I would love Victoria to be able to live a healthy, normal life, and she can see her, not only her children, graduation from high school, but from colleges and getting married and having grandkids.
Victoria hopes so too.
Not just for me, but for other people. This would be mind-blowing, and oh my God, I can't imagine, you know, the lives that could be saved if this thing actually worked.
That would be me.
Yes, it would be.
Now it's time for the nurses to get some of Victoria's blood for the study she's in. It's being conducted by 2 biotech companies and will eventually involve dozens of patients in the United States, Canada, and Europe.
All right, so how many days have you been here?
I think we're like day 80.
Oh, I can't believe you're really leaving.
As nurses Bonnie, Carol, and Brooke Ryan fill one big vial after another, I realized I never asked Victoria something. Is it weird to have genetically modified cells in your body?
No, I'm just genetically modified now. I'm a GMO, and is that what they call it?
Finally, the
We
nurses
can end
are
it
done.
there. I think
It's
that
time
was
to
a
say
big-
goodbye for now.
Good job.
This one,
You
this
did
is
it. Thank y'all. You're gonna make me cry. You're right.
But before I say goodbye to Victoria, I asked her about what comes next, this limbo period, waiting to find out if her supercells
now.
are working.
You can end it, that's fine.
Spiritual, I mean,
Unless you guys want to
it's
hear.
something I prayed about, and just the way everything happens for me, I just feel like it was fate for me to be here.
Yeah, so that was pretty much the gist of it. So really special story, I think. It can give you an idea of just, a patient's struggles with sickle-cell anemia and also how involved these trials are. She was in the hospital for 80 days. and now has to keep journals regularly afterwards for 15 years, actually, is how long the patient is monitored afterwards. So it's pretty significant, but it's pioneering. I mean, it's really like that doctor said, especially with CRISPR. CRISPR is still very new in clinical trials for sickle cell, but I think it is what is going to be the future. So finally, I know we're a little past 7, but I'll talk about what is Stanford doing. So Stanford University is one of the leaders in trying to develop CRISPR treatment for sickle cell disease. And in 2017, Stanford professor Dr. Porteous is his name, he was awarded $5.2 million to advance gene therapy trial for sickle cell disease. And essentially, he's in the Department of Pediatrics, and he's using a different CRISPR method for sickle cell disease. And he's still in development. So this is another article that came out in 2018. And so his lab is still working, doing the preclinical studies to develop the CRISPR treatment. But the hope when this was written in 2018 was that clinical trials would begin in 2019. And one interesting thing is that his studies and many of these gene therapy studies, these preclinical work that has to happen before clinical trials actually needs to use stem cells from healthy people in part of the development of the treatment. And so even in the Stanford cell therapy lab where they're trying to develop this treatment with Dr. Porteous, we are planning and hoping to be able to provide stem cells from healthy people that we enroll into our own protocol so that we can then supply this to this healthy donor stem cells to researchers to do the studies they need to do before they get approval to go into clinical trials. So we will be embarking next month on starting to provide researchers like Dr. Porteous stem cells for their studies for gene therapy. And that's essentially, I did have, how much time do I have left? Am I done? Maybe, do you guys want to hear like 3 more minutes? Okay, so this is ethics and cost. So I just have a few slides because that is something that does keep coming up about CRISPR. Some of you guys might have heard about some of these stories. So what are the ethics? It's still being developed, so the rules and regulations. It's like the science is moving faster than the regulations are right now, which can be scary, but that's what happens, I think, with a lot of new technology. So in 2017, though, a group with regulatory oversight for the use of human gene editing and the study of early human development yielded important knowledge and should proceed, but its use for enhancement should not be pursued. So basically, this group said, what is happening in sickle cell disease is you're not editing an embryo. You're editing, stem cells within the bone marrow. That's already partly differentiated, but a lot of the ethical things actually have to come with trying to edit embryos and fetal genes. So this group said that gene editing that results in the transmission of an edit to future generations might be acceptable, but under specific circumstances. But the criteria that has been created for germline editing have not yet been met and are very challenging to satisfy. Basically, it means there's a functional moratorium. But what happened, this is a slide that's showing some countries, so the US, we have intermediate legal regulations revolving around gene editing, but other countries like China, it's much more permissive. So the consensus of the committee that was looking at regulations and ethics around gene editing and gene therapy said that inclusive and transparent discussion of applications of gene editing in humans is critical. And everyone agreed on that. But then this story came out. So the need for transparency and many of the criteria of the committee were violated by an unethical application to embryos subsequently born as twins, and the researcher reported it at an international summit on human gene editing in November 2018. Who heard about this story? Yeah, right. We all heard about this story. So what exactly happened? So first, even though it was presented, thus far no report has been published and the outcome has not been verified. And Dr. Porteous, who's a leader here, he actually wrote this article talking about how this was not ethical and really violated the principles that are out there. And says even if the twins develop with no adverse events, the work was irresponsible and reckless and violated broad international norms regarding the application of gene editing to embryos. So what did he do? What did the scientists in China do? So this was in Nature, the Crispr baby scandal, what's next for human gene editing. So he claims to have disabled a gene, the CCR5 gene, which encodes a protein that allows HIV to enter cells. He was aiming to mimic a mutation that exists in about 10% of Europeans and helps to protect them against HIV. But he might have inadvertently caused mutations in other parts of the genome, which could have unpredictable health consequences. So he was pretty much trying to edit these babies' genomes to make them not susceptible to HIV. And I mean, the concept is revolutionary, but this is very, we don't even know what he's done to these babies. So far, they're okay, but where did it insert? There could be problems down the line. Before you do stuff like this, you have to have a lot of preclinical studies and approvals and regulatory oversight. So it really bypassed the normal pathway. And so questions are, what's going to happen to him and the children? How could his actions affect other research in the field? And where will the next CRISPR babies be born? Because, like I said, there's countries where there isn't that much regulation. And CRISPR is not that hard to do. I've heard that you can buy a kit online, and it's very, the technology, it's revolutionary, but it's not that complicated to actually do. The other ethical thing or thing to consider is cost. So this was also something that came out in a radio and news articles in May of 2019. So FDA approves Novartis's 2.1 million gene therapy, making it the world's most expensive drug. This was not for sickle cell disease, it was for spinal muscular atrophy, but it does show what the cost of this sort of therapy can be, 2.1 million, and Novartis said it could price the treatment between 1.5 million and 5 million. So what's the good of a cure if no one can afford it, right? So this is also a major, discussion that has to be had about these revolutionary therapies, but how do we make it affordable for people? And their argument is that, for example, spinal muscular atrophy, you pay all of this cost in the beginning to cure it, but now you have a young adult who has a whole full life ahead of them. And so they call it cost per quality life years. So even though this is high up front, in the end, because this patient is able to live so much longer and be a productive part of society, it makes up for that cost. So that is the argument that these companies are having. So I think with that's the end of my presentation. So today we covered how gene therapy has made major progress in sickle cell disease over the last few decades. Early data was not great with that first clinical trial with the lentivirus gene, but they modified the protocol and it works better now. Gene editing is now on the field with a lot of more CRISPR-based treatments for sickle cell disease. Transfusion requirements do increase in that peri-transplant period, so it can make it challenging to support them, but then ultimately you hope they will no longer need red cell transfusions. And the implementation of gene therapy will depend on a large extent to benefit risk and cost ratios. All right, thank you everyone. That was a long presentation. Do you have any questions or you wanted to do something before? Okay, so questions, yes.
Explain why, maybe I missed something, why you're providing stem cells from healthy people for the Porteous trial?
Sorry, let me just shut this off. So part of the development is they need to figure out how to, so one of the things I believe they do is how to target the gene. So in a healthy person, they will have a normal gene and you would still be able to build your guide RNA, let's say, to attach onto that gene. So that's just one example of why in the development studies they want to have healthy people's stem cells to help develop the treatment.
Therapy, because they're autologous, why is myeloablation still required for those patients?
Yes, that's a good question. I think it's because their own cells are not functioning properly. So any autologous transplant, you still need to do a level of myeloablation. And it's true, many times it does not have to be as intense as your allogeneic transplant, but you still have to do it to get rid of the patient's own cells that are not normal. So in this case, it's the progenitor red cells, in the bone marrow that are producing the defective sickle cells. So, but I think what these clinical trials, they had to boost the level of myeloablation. I think initially they were thinking it didn't have to be that much, but in that modified protocol, they ended up having to increase it, and they found that it worked better if you did that.
If gene therapy proves to be successful, do you have a rough estimate as to when this treatment might be available to patients after FDA approval? You're saying it's 5-7 years from now?
Oh, yeah, it's a good question. I mean, it's like the CRISPR ones, they're on a fast track approval, but it can take many years before the FDA approves these things. And it's also a matter of the companies that produce the lentiviruses or do the modification to be able to ramp up their production to actually do in actual patients. So I think years, so 5 years, 7 years is a pretty good. Mm-hmm.
And thank you for a great presentation, by the way.
Oh,
Very interesting.
thank you, thank you. Yes, another.
Were there any harmful side effects noted during the clinical trials of these therapies?
So the main ones were just the ones that you normally have when any patient needs to get a transplant, and they get myeloablated, so their own immune cells go down. Risk of infection is the big one. Needing transfusions to support until the engraftment occurs, but nothing specifically from the gene therapy. So the main things like I talked, the oncogenesis, they haven't found with the sickle cell gene therapy. They haven't found any issues with the lentivirus becoming activating and starting to propagate on their own. So far, and that's been the primary endpoints for many of these studies, is safety. Is this drug safe? And what they're showing is, yes, the drug is safe. The main side effects is just what you would expect from any patient going through a transplant. Yep.
I was just interested, the lady on the radio had 4 pregnancies, and I had a sense that people would have been much sicker and couldn't have carried 4 pregnancies through.
So patients with sickle cell can become pregnant and have children, but they're high risk. So she is very fortunate that she's had 4 children with very severe sickle cell disease, because she wouldn't have been able to be even enrolled in this trial unless she had severe disease, and probably required a lot of support during her pregnancies to manage them, because it is true, it's a very complicated pregnancy for sickle cell patients. Okay, great. Well, thank you so much. That was fun, and I hope you guys enjoyed this.